talk about PCSK9 biology beyond lipid control. There's something wrong in here. Are you able to see my screen share?
So we are able to see the first scene.
Yeah. Thank you, Vineet, for giving me the opportunity. And everybody who is going to listen to me. Well, it is very well known that hypolipidemia is a well-established risk factor for developing cardiovascular diseases. Multiple double-blind placebo-controlled trials have shown that statins lower LDL and reduce CV events in the individuals. However, CV death events continue to occur at some patients on statins despite receiving maximum tolerated therapy. Other patients develop side effects from statins and their use. Hence, newer modalities of treatment of lowering LDL cholesterol were needed in clinical practice. Recently, FDA approved 2 medications which target a novel pathway to reduce LDL cholesterol. They are monoclonal antibodies that inactivate PCSK9. How does PCSK9 work? Hepatic expression of regulated by SRBP2 and intracellular levels. These statins, acetamide, and bile acid binding resins cause induction of SREP2 and hence co-induce both PCSK9 and LDL receptors. A slightly increase in PCSK9 activity seen with the statins, and PCSK9 reduces the number of LDL receptors in hepatocyte by promoting their metabolism subsequent degradation. PCSK9 has been shown to act both intracellularly as well as a secreted factor promoting LDL receptor internalization from the hepatocellular surface. And under normal circumstances, LDL and LDL receptor complexes endositized by endosomes. PCSK9 inhibitors are protein made in labs. They target other proteins in your body, specifically your liver. Your liver cells have receptors that sweep away excess cholesterol. But another protein called PCSK9 destroy those receptors. That's when inhibitors come in. They latch into PCSK9 protein and block them from acting on them. The result is that receptors are able to do their job, which is to decrease LDL cholesterol in your blood. Is a dramatic representation of the same. You see attached to it, and it destroys the LDL receptor by lysosomization. How it works? Receptors endosomized, and then LDL cholesterol decreases in our blood. Now, PCSK9 inhibitor strategies, there are 3 strategies that have been investigated. Inhibition of production of gene splicing through antisense oligonucleotides or small interfering RNA. Prevention of PCSK binding to LDL receptor using monoclonal antibodies, which is what is more important at the moment. And inhibition of PCSK9 autocatalytic sites. Now, the first one is the gene splicing thing that is under investigation, and we do not have any molecule as of now approved by FDA using this particular strategy. Monoclonal antibodies is what we have in the market at the moment. Presently, 6 monoclonal antibodies have been developed and tested. First one is the second one, adalimumab and evolocumab have been approved by FDA. Third one, bococizumab is a unique and monoclonal antibody which utilizes pH-sensitive binding to PCSK9 and was developed for a longer serum half-life and duration action on LDL reduction, but it has not yet been approved for usage. Inhibition of autocatalytic site is another strategy that is under evaluation. Now, FDA has approved these 2 monoclonal antibodies that I mentioned. Multiple clinical trials have shown the benefit of these two monoclonal antibodies with the reduction of LDL from around 40% to around 65% with alirocumab, and almost similar or little better effect with evolocumab. Is there any side effect of these drugs? Well, the side effects are mild, usually back pain, symptoms of cold and flu, and allergic reactions some patients, as is with any other drug. Effect of PCSK9 on lipid levels. Well, PCSK9 inhibitors decrease availability of ApoB. It increases LDL and ApoA. Inhibitors and it decreases lipoprotein A. These are the effects which are not seen with statins. As far as endocrine system is concerned, there is insulin, growth hormone, estrogen, thyroid hormones that affected a bit, but not much. Alirocumab does not alter level of steroid or gonadal hormones. Statins increases slightly the risk of new onset diabetes mellitus. The similar also, but in large clinical trials, no such risk has been seen till now. And whatever risk, if at all is there, the benefit of reduction of LDL cholesterol overweights in increase of diabetes. As I said, these molecules are also expressed in other organs. It is expressed in intestine, cephalocaudal axis in human enterocyte, jejunal ileum. PCSK9 modulates intestinal secretion of triglyceride-rich particles. As far as kidney is concerned, it is involved in nephrogenesis. So exogenous administration of PCSK9 in vivo decreases LDL receptor expression in kidneys. PCSK9 deficiency does not alter any blood pressure. Amiloride increases urinary sodium secretion, PCSK9 deficiency though. And patients with PCSK9 allo variety are less prone to hypertension than non-carriers. Some studies are reporting no association between estimated GFR and circulating level of PCSK9 and other findings, and inverse correlation 1998. Though these things are still under investigation and we do not have a final word on it yet. PCSK9 and CNS is important. It might be involved in CNS, development of CNS. Protein is transiently expressed in embryonic brain telocephalic neurons. Transfixion of PCSK9 in telocephalic cells in early development was shown to result in recruitment of undifferentiated neuron progenitor cells, and breakdown of PCSK9 mRNA using antisense oligonucleotides resulted in the loss of CNS structures. PCSK9 has been implicated in neuroplasticity cases and also associated with fetal neural tube defects.
Thank you. Thank you so much, Dr. Deepak.
I'm sorry. Got stuck.
इसमें कुछ गड़बड़ हो गई लगता है. फिर से स्लाइड फिर से शेयर कर लीजिए.
Is it visible?
Yes, visible.
We were here. The result of two approved fully human antibodies. This was published in 2017. And the PCSK9 binding antibody influence on cognitive health in high cardiovascular risk trial was sub-study for founder trial that included 1,204 participants. And excessive function, working memory, episodic memory, and psychomotor speed. No effect of alirocumab added to statin therapy was found on cognitive function. So we can say that exposure of PCSK9 and LDL are not associated with neurocognitive effects. As far as the immune system is concerned, PCSK9 causes vascular inflammation and atherogenesis. PCSK9 is vascular smooth muscle cell, increases pro-atherogenic receptors, oxidize the LDL cholesterol. So increase in PCSK9 increases pro-inflammatory leukocyte 6C high monocytes and atherogenic plaques. So effectively, PCSK9 inhibition should reduce atherosclerotic plaques and inflammation. The transcriptional regulation of PCSK9 suggests a potential role of PCSK9 in inflammation, and lipopolysaccharide induces PCSK9 mRNA expressions in liver, kidney, and endothelial vascular smooth muscle cells. Circulating concentration of PCSK9 are increasing systemic inflammation, sepsis, and trauma. So PCSK9 increase during sepsis was associated with multiple organ failure. After ACS, PCSK9 increases 12 to 24 hours, and it also increases CRP, white cell count, fibrogenic levels, and leads to coronary artery disease. So PCSK9 is implicated in vascular inflammation, promoting the secretion of pro-inflammatory cytokines from macrophages, upregulation of hepatic LDL receptor by PCSK9 inhibitors promote liposaccharide in clearance, decrease inflammatory response, and improve survival following sepsis. So it is quite possible that very soon these drugs will be indicated in treatment of sepsis. Potential link between PCSK9 functions with infectious diseases is under investigation, specifically hepatitis C virus. By modulating LDL receptor expression, PCSK9 affects hepatitis C entry into liver cells through ApoE-mediated and ApoB-mediated uptake of lipoviral proteins, particles. PCSK9 down-regulates the expression of CD81, which is a cell surface protein that promotes the entry of hepatitis C into the hepatocytes. So pre-treatment of liver cells with recombinant PCSK9 inhibitor inhibits HCV infection in dose-dependent manner. PCSK9 inhibition, alirocumab does not affect the expression of CD81 or entry of hepatitis C virus particles into HUH7 cells, suggesting that blocking extracellular PCSK9 function would be neutral regarding the risk of hepatitis C infection. As far as the cancer is concerned, PCSK9 is involved in both cell proliferation and apoptosis. So modulation of these particles might have a role in cancer. In summary, 2013 American College of Cardiology and American Heart Association recommends on cholesterol management centered on identifying patients who would have reduction in CV death events with statin treatment. The focus shifts from treating to a specific LDL level to treating at risk individual with treatment with statin proven to reduce future CV events. Subsequently, improved IT trial demonstrated that addition of ezetimibe to simvastatin lowers LDL cholesterol more than that achieved by simvastatin alone, and that this reduction in LDL cholesterol was associated with a greater reduction in CV death event compared with simvastatin alone. PCSK9 inhibitors are specifically beneficial in the treatment of familial hypercholesterolemia patients who are are intolerant to statins or have an elevated LDL levels despite being on maximal tolerated statin therapy. Addition of PCSK9 inhibitor to low dose statin therapy would be more effective in lowering LDL and avoiding the side effect of statins, since low dose and high dose statin regimens have yielded similar efficiency when combined with PCSK9 inhibitors. Potential barrier to widespread use of PCSK9 inhibitor is their cost about $14,000 per year in US. PCSK9 therapy is a welcome treatment option for statin tolerant patients who require treatment to their hyperlipidemia. Thank you.
Thank you so much, Dr. Deepak. That was a wonderful presentation on a novel molecule, though not very frequently used, but it has its own place. Any questions for Dr. Deepak?